There are elements in there that put the decision-making back in the hands of individuals, so the individual mandate goes away, as well as mandates for businesses to provide insurance. And you know that 50 employee threshold has been a significant issue for a number of businesses. So those things get set aside. We do preserve the requirement that insurance companies write insurance for those individuals with pre-existing conditions. It's clear in the bill. I want to be direct and unambivalent about that. That is exactly what is in the bill. I also want to let you know that we are providing the opportunity for states, if they so choose, to look at other minimum requirements that would be in a health care policy. Right now, there is a minimum set of requirements that's set at the federal level. Each state, though, many times has set their own minimum requirements of what has to be in a policy that's marketed as health insurance. What we have said is we will allow states, if they so choose, to apply for a waiver to the federal requirements. And again, the waiver has to require these elements. They have to show that it reduces cost, and they have to show that it increases coverage so they can bring more people in and reduce cost. Again, a common theme throughout here: more choice, more access. The same with the process on community rating. So community rating is how insurance companies determine what will be the need in the community to provide the dollars to cover those medical procedures that the insurance policies are meant to address. What this says is that there are different ways to do community rating. There are processes, things like invisible risk pooling that states like Maine have used that have been very, very successful. This bill allows a state, again, to apply to use an invisible risk pool if they so choose. Again, it has to show that it reduces cost, increases coverage. We provide some additional dollars there, so if they put an invisible risk pool in place, we will help in making sure that in the underwriting of costs there, from the healthiest people to the least healthy people, that we cover the cost in there to make sure there are no losses, to where they can structure that, again, to where you can bring down health care premiums. So all those are important parts of the bill. Again, they first step in the process. This is 1/5 of the process. The Senate will now put together their bill. It has to get through the Senate with 51 votes. Then that bill will be put into a committee of conference with the House bill. A bill from there will be the product, and then it goes back again to the House and to the Senate, where it has to get a majority of votes in both bodies before it goes to the President's desk. So it's a long ways away. I know there's been a lot of great information shared with us about what to do to reform health care. I know Mr. Trampy has been extraordinarily thoughtful in giving us information, as well as I know others on the board, to let us know what we need to be doing to address this issue. So I wanted to update you so that you heard it directly from me, as well as the citizens here in Spotsylvania County, to understand what our efforts are doing, and that is to make sure the entire focus here is to be able to bring down cost and provide choice to individuals so they can best fit their family needs and their budgets with managing their risk with receiving health care. Those are the key elements of this, Mr. Chairman. So we look forward to this being the first step in that process. Lots of debate, obviously lots of passion in this, but we want to make sure people understand clearly what is in the bill. It's a pretty simple and straightforward bill. There are several amendments to it. The bill itself is about 138 pages. The MacArthur amendment's 8 pages, and the Upton-Long amendment is 1 page. So it's simple and straightforward, and we make sure that we'll have that accessible here to the board and then for your constituents, and we'll also make it available to anybody that wants to contact us so they can actually read the legislation. We think that's extraordinarily important.
Thank you, Mr. Chairman. I have a few questions on the health care issue.
Sure.
When the Spotsylvania Department of Social Services has been before us over the years, I've asked them about the Medicaid program and the availability of providers, and they've basically confirmed what I've heard elsewhere, that there's a chronic shortage, particularly if you need a specialist, and particularly those willing to see new Medicaid patients. And along when aides to Governor McAuliffe spoke to the finance of counties about expanding Medicaid, I asked them how they plan to shoehorn tens of thousands of new patients into a system that already has a chronic shortage of providers. And essentially they said they agreed that reform was necessary, but that the last administration wasn't going to allow any waivers unless a state first expanded Medicaid. So, make a long story short, my question is, does the bill that the House just passed allows states to reform Medicaid along free market lines to allow new providers to come in?
Dr. Trampy, it does, and it does it by this mechanism. It will then block grant dollars to states, so it sends the entirety of what comes to states down to the state level. What we have done to try to assuage the issues between expansion states and non-expansion states is to make sure that we have put a few additional dollars in there for the state of Virginia as a non-expansion, still less than what it would be for an expansion state. So there's still some back and forth about saying, well, Virginia should, since it's been frugal, should not be penalized for being frugal. So I still think that there's some room for debate on that, but the dollars will be sent to the states. There is encouragement in there, too, for states to be innovative with those dollars. And again, the focus is with those dollars to be able to serve additional people. So there are some additional resources, too, to encourage states to use different pilot programs to find ways to provide the incentives for providers to see Medicaid patients, to make sure, too, we're looking at Medicaid reimbursements. As I talk to doctors, there's a lot of issue back and forth with that, cost versus reimbursement, to make sure there's timely reimbursement, and to look at ways where we can coordinate care to make sure, as you said, that there's not a duplication of care, to look at ways to be able to attract specialists in, to be able to see Medicaid patients. All those are things that are being encouraged in the bill in how it sends money down to states and encourages them to use best practices and to share information across states. States have done that have been successful in increasing the number of patients seen and bringing down costs.
The bill replaces the Obamacare subsidies with what are referred to as refundable tax credits. Can you briefly tell our audience what a refundable tax credit is?
Sure. Well, normally you file your tax return and you get that return potentially based on loopholes or exemptions, the ability to take off the top line of your taxable income what your tax liability is. And then if you have paid more taxes than what you're liable for, you get those taxes back. But you have to wait until the end of the tax year in order to do that. What a refundable tax credit is to say we're not going to wait until you put your tax form in. We're actually going to send those dollars to you so that you can use them to be able to purchase coverage. So it's the same as a tax refund that you would get in a tax reform. It's just the immediacy of being able to get it so that you'd have that cash in hand to purchase an insurance policy.
And if you don't have enough income tax liability against which to take the credit, what happens then?
Well, you would still receive a credit. It would be based on your qualification of income and being able to purchase insurance. So it would be much like what we see now in the earned income tax credit. So you may not have taxable liability, but if you are working, then you would actually get dollars back in addition to, or if you have zero tax liability, you'd still get those dollars back. So it's not based on your total tax liability. It's about whether you qualify based on income to get that assistance to purchase insurance in those exchanges, which is what you receive today, only in a different form. This is done in the form of a tax dollars that come back to you to be able to purchase that insurance.
And currently the credits go to the insurance company after the patient has chosen it on the exchanges.
That is correct.
But yeah, these credits would go directly to the patients, is that correct?
That is correct.
So
yes.
If they wanted to put a piece of it in a healthcare savings account and use the rest for a catastrophic policy with low premiums, they would have that choice?
They would have that choice. And remember, in this bill, too, we have increased the limits on HSAs and taken away what are now limitations on using HSAs. As you know, today, the HSA is limited at $2,250, and it also requires that even if you go get off the over-the-counter medication, you have to get a prescription in order to have that qualify to use your HSA dollars. Those requirements now have been set aside so that you can freely use that. And as you said, those dollars from the refundable tax credit can go to be used for the purchase of the health care that's best for you and how you best determine the use of those dollars.
Now, what I've heard is that the credit is available if you do not get health care through your employer or Medicare or Medicaid.
That is correct.
So would that include someone below the poverty level who in their state is not eligible for Medicaid?
That would be correct. If you're not eligible for Medicaid or you're not being provided insurance by your employer, you are eligible for that. It relates to about 7% of the population is the latest figure that I've seen. So.
Because that population is actually not eligible for the Obamacare credits. That starts at 100% of the poverty level.
That's
and goes
right.
up.
And goes up. That is correct. So this is meant to be a way for folks to access those dollars that are outside coverages from those programs: Medicare, Medicaid, employer-based health care coverage.
I do want to address a couple of the criticisms I've heard from conservatives about the bill. The basic complaint, particularly now that you've addressed pre-existing conditions, the usual complaint is that you're creating a new entitlement. But by block granting Medicaid, doesn't that remove the federal entitlement for that program?
It does. It makes it in that way solely a state program. As you know now, there's a state and federal component to that, along with requirements at the federal level for Medicaid. This takes those away and says it's a direct block grant to the states.
And the new entitlement is replacing the Obamacare entitlement. Is that correct?
That is correct.
So
yes.
really you're eliminating two while creating one new one.
That is correct. You're consolidating it into a single program versus multiple elements of the program under the Affordable Care Act, yes.
And this one I only came up as you were speaking earlier. When the original version of the bill was first introduced, Speaker Ryan talked about a three-step process. One of those steps, I forget if it was 2 or 3, was for Secretary Price at HHS to eliminate a lot of the regulations, particularly the mandated benefits. You mentioned that states are going to be allowed to do that. And I know you don't speak for Secretary Price, but will he still be doing his part to eliminate those regulations at the federal level at the same time that states have more flexibility?
Dr. Trampy, it's my understanding that he will. It's my understanding he's going to look across the spectrum about what enhanced health benefit requirements are at the federal level, look at how those are either providing care for folks or driving cost, and looking at ways to make sure, again, we address cost and making sure that people have access. I can't think of anybody better having a broader, expansive experience than Dr. Price to be able to do that. And again, by restructuring that at the federal level and then also empowering states for them to come back and say, listen, we've got a better way of doing things. And as you know, in Virginia, when I served in the General Assembly, each year we had a whole slate of bills that came in for folks saying that insurance in Virginia that's marketed as health insurance needs to cover certain things, whether it's a particular type of cancer treatment. And of course, you can add those things, but they also add to costs. So the General Assembly finally said, we're going to assign a civilian board to make those decisions, and then they make a recommendation back to the General Assembly. So each state, in most instances, already looks at what is a minimal requirement in a health insurance policy. So the question then becomes, who's better off to do that? Is it better off at the state level, or better off at the federal level? So if states believe they've got a better handle on what their state needs are and how they can better manage cost, this allows them to do that. Again, with the caveats, when they make that application, they have to show that it brings down cost and it also expands coverage so they can cover more people at a lower cost. Those are the requirements, and they're clearly stated in the bill to do that. So we think it's a good step forward. And it encourages states to think creatively and not just say, hey, this is all a federal element. A lot of states have got some pretty good ideas about how to manage cost and how to make sure that they get care to the largest number of people.
Thank you, Mr. Chairman.
Mr. Sabula.
Thank you, Mr. Chair. Congressman Wittman, I just want to thank you for being here
Thank you.
And answering these questions. And I also want to thank you and your colleagues for passing a bill that's actually readable at under 150 pages. I think that's critical. As a senior citizen, I get a lot of comments and complaints about Medicare from constituents, and I have a concern of my own, and that is, as an example, I have a doctor who accepts my insurance, Medicare, and I have TRICARE for life coverage. This is all well and good, but my doctor is going to retire. And now I have to find a physician who will accept Medicare.
Yes.
Never had a problem with TRICARE for life, but one that will accept Medicare. And this is a common complaint that comes forward all the time. I can't find a doctor that will take Medicare. And of course, when we turn 65, we automatically are required to convert to Medicare, and this creates a problem. Is there anything that you see that can be done at your level that'll help this situation?
Well, we've done some reform to how Medicare reimbursements took place. As you know, there was an automatic cut that was looming out there called the Sustainable Growth Rate, or SGR, that threatened every year to reduce those reimbursements. We finally set that aside, but we set it aside with a reporting system now that physicians have to go through in order to report how they provide Medicare services. So it is actually a little more paperwork for them, which was really not the intent. It was to try to take away the threat of those draconian cuts. So many physicians look at it and go, I already have to do enough paperwork. So for some instances, that's problematic. They have to show coordination of care, which is not a bad thing because you want to make sure you're not duplicating care across different physicians. Many times people in Medicare see a number of different physicians, so you want to make sure there's coordination of care there. That's a good thing. What we have seen, though, is that there continues to be a challenge with the reimbursement rates under Medicare. And if you look at that, I think the latest figure is about 83 cents on the dollar is what physicians get reimbursed. So for many of them, they have to have the proper mix of patients. So they can only take so many Medicare patients, so many Medicaid patients, because they're actually reimbursed below what their actual costs are, in addition to insurance pay patients where they can actually balance the books to make sure they're making some money. So when you see the instances where physicians are saying, I can't take any more Medicare patients, it's normally looking at their patient mix and what they get reimbursed. And as more and more people age into Medicare eligibility, the demand is exceeding the supply. And it's even broader than that, Greg. What we see is that as you get into discussing the American Health Care Act, or the replacement for Obamacare, the question then becomes, if we are going to now have more patients that have insurance and have access to care, how do we address the supply of physicians? So it becomes another supply and demand model. How do we make sure we have enough out there? Because if we keep putting more people in, and there's a finite number, or the number is not increasing, then what happens? Wait times get longer. It does affect price. What we've seen, too, as an outcome of Medicare is, and what's happened with the Affordable Care Act, is that some physicians have said, hey, I'm done. I'm just going to do concierge medicine. So you pay me a retainer, pay me based on cost, and I'll see you. I'm going to carry a patient load of X number of patients, and I'm it. I'm outside of the system. So again, it gets to creating a two-tiered healthcare system potentially with that. So we still have some things that have to be addressed with Medicare as far as the reimbursement rates. I think some of that has been fixed with coordination of care, but not all of it, because you still have physicians that have a challenge with taking on more Medicare patients solely because of what they're being reimbursed by the government for those services.